Okay, howdy, we're back. Still in Valley Medicine. Been a long time since we talked, but I'm going to get this out. Come hell or high water. I told some public health folks that I was going to get malaria out to them. I wanted it to be TB, malaria, and rabies, but guess what? You just get malaria only, which malaria was a way bigger topic than maybe I thought it was going to be. So it's a lot to chew on, but malaria is definitely a cool one. This is actually the second time recording this video because the first time it didn't work. So we're going to do our best to make this one happen and make it stick for good. Okay, so malaria coming at you. Way more interesting than maybe I thought it was going to be. Okay, here's what we're going to talk about: history of malaria, impact on the world and distribution, pathophys, treatment prophylaxis. As usual, my favorite part is going to be the history and the impact on the world. I think that was just so interesting. Pathophys, dude, just gut it, get through it. Like treatment, cdc.gov is the place to go for that. We'll talk about it certainly. And then prophylaxis is the same. Go to the CDC. It's complicated, changes all the time, but the history impact on the world is really, really impressive. And then the pathophys, it's just malaria is an elegant disease. It's complicated. It has carved out a unique niche in the world that unfortunately many other diseases, except for TB, I'll say, and maybe HIV. But yeah, malaria particularly brutal. And we're gonna talk about it. All right. I have no disclosures, dude. I wish I had some. Send me some. Send me anybody. I just make them for free, because I think they're fun. I don't speak for the DoD or the JTS, although we do cover DoD and JTS topics from time to time, and we do speak on the military frequently. But I don't talk for them. They talk for themselves. This is all just my opinion. It's based on my interpretation of other people's opinion and other people's data, own experience and bias when it comes to malaria. Thankfully, I have no bias because I've not treated one person in my whole career with malaria. Cool. History. Malaria is named after an Italian term that I won't butcher, meaning bad air. Talk about Italy and malaria later. It's old. It's old disease. Not exactly how old, but intimately connected to humans, has shaped the course of human history, most certainly, as has TB and plague and some others. But the oldest attempt at treatment is 168 BC in China that I could find. Artemisia annua, also known as sweet wormwood, and we're going to take a trip back to China here in a minute to talk about more China malaria later. But that's the first attempt at treatment that I could find. Who are these people? This guy, I'm going to do my best French. So, Charles Louis Alphonse Laveran was a French physician who was awarded the Nobel Prize, which, if you didn't know, that's what that looks like. And Alfred Nobel, if you didn't know, big dynamite guy, supposedly the inventor of dynamite, who didn't like that was its reputation, so he came up with the Nobel Prize. I think that's true. But this guy, Charles Laveran, French physician, awarded the Nobel Prize in 1907, in part due to his discovery of the protozoan, which is a unique type of life form, protozoan responsible for malaria, while working in Algeria with the French army. At the time, Charles, I should say, donated half his Nobel Prize money, awarded to him for the construction of a lab dedicated to the study of tropical diseases. I don't know what people who win the Nobel Prize do nowadays with their money, but Charles was very nice, and he donated his to the study for a tropical disease lab. I don't know what the 1907 prize money was for the Nobel Prize, but right now the prize money is about $1 million. Okay, so there you go. Go Charles. Charles. All right, and then this lady, second Nobel Prize for the same disease. In 2015, another Nobel Prize was awarded to Tu Yu, which is her name. Tu Tu, and then the word U and the word U. Tu Yu, a Chinese pharmaceutical chemist who discovered artemisinin after working again with the sweet wormwood to develop an extract that is currently recommended in most malaria treatments around the world. There you go. Tu Yu, go you. All right. All right. Here's some malaria facts. This one's kind of depressing. Then I'm going to show you a cool website. So, 2023, 263 million malaria cases, 600,000 malaria deaths in 83 countries. That seems extremely broad and just devastating. So 263 million cases, 600,000 deaths, but it's in a small part. Most of the World Health Organization Africa region says that 94% of the malaria cases and 95% of the malaria deaths are in Africa. Okay. Of those, of almost all of the cases, half are in 4 countries. We'll talk about that. Then the disturbing part about all of them, of all the deaths, of all the 600,000 deaths, children under 5 accounted for 76% of all the deaths in the Africa region. 3/4 are children under 5. It's a particularly disturbing statistic. HIV positive patients and pregnant patients also make up a massive percentage of that number of people who are vulnerable at risk. But this researching this disease was particularly just sad because I have small children, and yeah, it was disturbing the amount of pediatric death that the continent of Africa bears every year because we just tolerate it as a species. So all that death is isolated to 4 countries. So Nigeria, DRC, Niger, and United Republic of Tanzania. Some of those have better governments than others. Some of those are more stable than others. Niger recently underwent a coup, so I wouldn't describe that as super stable. DRC also perennial problems. Nigeria, has big cities and some modern infrastructure, but also perennial problems. Republic of Tanzania is further out to the south and the east, I believe, but these other ones are kind of in equatorial and coastal Africa. Certainly Nigeria is like on the coast. There we go. Cool website alert. Get out of this view and go to the website. I found this website like doing this. Oh yeah, there you go. My Loom app wasn't working, and so I had to shoot the entire video over again, which was awesome. Okay, it's a cool website. I won't belabor it too much. I talked about it way too much on the original version of the video, so I won't do that again. Here's the death rate from malaria when you go to Niger. Wow, 132 people per 100,000. That's a lot. Okay, when you look at all the death on the whole earth, there's like none anywhere else except in Africa. And then a couple other places, Papua New Guinea, sort of like ancient land, like not real government, and then Guyana. Okay, so the only 2 places are basically, Yemen, not real country either, really, just lots of strife and humanitarian disaster, but then almost all in Africa. Okay, here is the death rate, which is like pretty disturbing. So 134th people per 100,000, which is just like a wild number. And then here's some sad ones. So the purple or blue, whatever you're going to call that, that is the malaria death by age in children under 5. So that takes up most of the graph. Okay. Most of the graph is children under 5, which is very just disturbing. And then when you look at malaria deaths by region, it's Africa only. It's basically just Africa. Okay. The rest of these people, Europe, South America, North America, and Oceania, and Asia, are just letting the Africans die. And there's a lot of reasons for that, right? Like political instability, sectarian violence, war, famine, lack of viable economic opportunities. And so countries that have stuff don't look to Africa because there's nothing, they have nothing to lose by being in Africa, so they don't go to Africa. Okay, we'll keep going. This is the mortality in children, which is particularly disturbing. So 440,000 kids in 440 kids per 100,000. So, and then you go to a place like Burkina Faso, so like think of the percentage of people that is. So per 100,000 people, so 10% would be 10,000 deaths. 5% would be 1,000 deaths. So in Burkina Faso, 2.5% of every 100,000 kids, dying. Like that's just like a crazy number. And then here, nope, this is all death. Okay, so kids sleeping under insecticide-treated nets. So in places where like malaria is so common, so like only half the kids are sleeping under mosquito nets. That's one of the primary preventions for malaria, which we're not going to cover in this lecture because otherwise this lecture would be 45 million hours. One of the primary prevention is sleeping under mosquito net, and just only half the kids are doing that. Here's a percentage of people in the country that have malaria. It's gonna in Niger, 17% of people have malaria. Nigeria, 20% of people have malaria. DRC, 23% of the people just like have malaria. It's just ridiculous. It's just absolutely insanity. And then it countries that you don't really think of malaria that much, like India. Here's Afghanistan. They go, less than half, less than 1%. Pakistan, there's some, but some of these other places, Colombia, Peru, Guyana, they got the malaria too. Haiti, Nicaragua. Honduras, you don't take malaria prophylaxis there, but anyway, all right. There's a bunch of malaria everywhere. The toll is wild, and unfortunately, it's heavily the toll is heavily borne by children. Frankly, all right. This is one of my favorite parts: the malaria impact on military conflict. So, who's this guy? This is the mosaic of Alexander the Great. Okay, Alexander the Great, massive conquest in the ancient time, went all the way, conquered Macedonia, modern day Saudi Arabia, Syria, east into Afghanistan, like all the way into India and Babylon and all that kind of stuff. So he died at the age of 32 in Babylon at 323 BC. There are many scholars that believe that he may have died of malaria. I think the the prevailing theory is that he actually died of typhus, but I like the idea of him dying of malaria because it helps this lecture better. But, big name, maybe taken down by malaria. That's the point. All right, cool. Roman Empire, 117 AD. I have no idea if this is the height of the Roman Empire or not, but this is the picture that we got. And so there's lots of instances of malaria affecting the outcome of military campaigns and military battles due to sick soldiers. Okay, and so at one point the illness was so common in the Mediterranean that it was referred to as the air of Rome. And even its namesake is Italian. And so some suspect it protected the Romans from invaders as they were prone to debilitating malaria due to campaigns against the Roman state. And so in the seasonal times when it was warm, that's when you go to war. You don't go to war in the winter, not really. And so these invading armies would come in, attack the Roman state. They would get wrecked with malaria. The Romans, maybe they were partially immune, and they would, defend their city states and be victorious. Who knows? It's a good story though. And then top right is the Crusades. Malaria is suspected to be the cause of up to 35%, so like more than 1/3 of the deaths of European soldiers in the first 3 years of the Third Crusade. And so, yeah, malaria gets everybody, even the Crusaders. Top left, one near and dear to us. There are some historical accounts that the British Army of the South that eventually surrendered, I believe, at Charleston during the American War for Independence, that up to like 50% of their soldiers were infected with malaria and very ill, and which certainly decreased their ability to fight back. So maybe you could say the American experiment is partially successful due to malaria being endemic to the southeastern United States at the time and killing all the British soldiers. Who knows? These other pictures, these men didn't take their Atabrine or Atabrine, and then these like pictures over here. These are from World War II. Just a stupid number. So 572,000 cases of malaria of U.S. soldiers in World War II. And then here's a picture of southern Vietnam, 60,000 cases in the Vietnam War. And so, yeah, who cares, Sean? These are all old. This is actually, sorry, before I move on to that, this tells you how much malaria there was. And so in certain areas, there was just much more malaria than others, but this is mostly in the South. This is all old, even Vietnam, people think it's old. It's like super long time ago. It's really not that long ago, but people think it's a long time ago. But actually, we have malaria cases affecting our own military much more recently than that. This is Russ Cutwall. We cannot get rid of him. I am the captain of his fan club. He just writes everything that we find for this series, and he writes it all about Ranger Regiment. And so we're just going to follow Russ Cotwall, come hell or high water, wherever he goes. We'll follow him through the fire to the truth in the universe, and that is that malaria still affects us today. So this is I suppose it's a case series. I don't know, case series, I guess, of 38 cases of malaria, 700-person Ranger task force deployed to Afghanistan. It basically showed they didn't take their prophylaxis. Nobody died, but some of them got sick. They don't have the crazy bad malaria in Afghanistan, but they did get malaria. And so just because we are not fighting in the Crusades or during a campaign against Rome doesn't mean that we cannot also get malaria, especially if we go back into Southeast Asia, like some people think that we may be doing. Cool. Pathophys. Complicated. Malaria, vector-borne, meaning you get it from something else. It's a parasitic disease caused by the protozoan parasites of the genus Plasmodium in tropical and subtropical regions. The main ones are Plasmodium falciparum, Vivax, Malariae, I'm just going to say malaria, Ovale, and Noalessi are the 5 known species that cause malaria in humans. Noalessi is like a primate version, but it does affect humans too. And then falciparum and Vivax are the most concerning to humans and causes the most sickest. Ovale is unlikely outside of Africa. Plasmodium malaria is not like a dominant strain of malaria, but it is found in most places. And then Noalessi is the primate one that can affect humans, mostly in Southeast Asia and Brazil. Okay, here's the insect vector. It is the Anopheles mosquito. Only the female mosquitoes bite, and so it is the female mosquitoes that carry the disease. You can also get it through contaminated blood and needles in endemic areas. Children, pregnant women, HIV positive patients are the most at-risk populations. I think I said that before. Like we said, 3/4 of the people who die are children. I mean, it's just like ridiculous. It's so disturbing. And then highly endemic areas, immunity can develop after multiple infections. I have a personal story on this. So I've talked to patients who are from Nigeria frequently. I just have like a Nigerian population here where I live and work. And I asked them, hey, I got this thing about malaria. I kind of think it's cool. Like, tell me about malaria. Oh, yes, had malaria a million times and blah, 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 blah. Then they have small children who have been born and raised in the United States. I said, hey, do you ever go back to Nigeria? They say, yes. And I say, do you give malaria prophylaxis to your children who are American and therefore weak and not immune to malaria? They say, and they look at me like I'm dumb. They say, no, of course we don't give our children, malaria prophylaxis. But I think they are really rolling the dice. And I have talked to them and say, hey, even though you are immune to malaria because you lived in Africa for 30 years, your children are not immune from malaria. And they should fully get prophylaxis, so they can avoid infection when they go back to Africa. Because, if you're 30 years old and you were born in Niger and you lived in Niger for your whole life, you will have had malaria 10 times and you will probably be immune to most strains. But people who are not born there, even if they are your offspring, are not going to be, immune to malaria. Okay, this is like the picture from hell that I'm just so furious that the previous video did not record because I have to go over this all again and it's complicated. This is not, on the test or whatever, and so just work through it with me. Okay, here's the life cycle of malaria. I think I described it as elegant before. It is. It has carved out a unique niche in the world, and I sort of respect that. I think it's cool. It has found some unique solutions to a couple things. It can be particularly challenging to get rid of because of its specific life cycle. So we're going to go through it. So this is the female mosquito bites you because you're too freaking stupid to wear your long sleeves or your bug spray or your malaria prophylaxis. And then it injects the sporozoites into your body within an hour or two. They're in your liver. Usually within 2 to 4 weeks, you are going to show signs and symptoms of malaria. It enters this liver stage, and then some of them become dormant liver cells, and they live with you forever. If you have Vivax or ovale malaria, they stay inside your liver until you take meds to get rid of them. These are these meds right here. I know the picture's blurry. I'm sorry. Like, they don't make the pictures for my presentations. I make the pictures for my presentations, so you get what you get. After a certain period of time, these ruptured schizoints, whatever, they rupture out of the liver and they go and find your blood. So they find your blood cells, they infect the blood, and I'm sorry, I keep pointing with my pen and you can't even see that. So they infect the blood down here, and then these early trophozoites, they go up and they form this gametocyte, which gets sucked up by other mosquitoes that are biting you to then go carry off and bite other people. Some of the other blood stage schizont, I don't know how to say that. They infect lots and lots of red blood cells, and then they synchronize their rupturing of the red blood cells, and they cause this relapsing and remitting fever, this intermittent fever that comes on when they rupture. It's every couple days. It depends on the species, and they go on, and then all these release, and they go and infect more red blood cells. So you have this massive amount of red blood cell production. For Vivax and Ovale, you can get sick right away, within a couple weeks, or you can also get sick months later due to the residual hypnozoites in the liver, and so that can definitely happen. And so you have to take meds that are specifically targeted to those. All right, so why is this so complicated? Well, there's complicated malaria, and there's uncomplicated malaria. This actually should be uncomplicated because severe malaria and complicated are the same thing. Then there's malaria that is species specific, then there's drug resistant malaria. So malaria is heavily studied. It's a scourge upon the earth. And so when things are heavily studied, they get more complicated. And when we start treating things with certain drugs, things develop resistance. And so then we have to find areas where the resistance isn't more prevalent or more prevalent. So that's a major problem with malaria treatment currently. Uncomplicated malaria can be any species. Typically, you get high fevers that are classically intermittent, comes and goes. This isn't always seen, but tachycardia, tachypnea, diaphoresis, paleness, body aches, headache, cough, nausea, vomiting, kind of flu-like symptoms. And then some weird ones are certainly you get the paleness secondary to the anemia, splenomegaly, and you get a mild jaundice from the bilirubin metabolism from the ruptured red blood cells. Labs can show a certain level of parasitemia that's so parasites in your blood under 5,000 parasites per microliter. You do get thrombocytopenia, so low platelets, elevated liver enzymes, that kind of stuff. And then severe or complicated malaria, most often caused by falciparum, but can be caused by other species, specifically Novalesci and Vivax, but often caused by falciparum. Falciparum is the worst. Falciparum is the Darth Vader, okay, of malaria. It is the Satan. It is the Darth Vader. It's the I don't know, the guy from Harry Potter, like whatever that, the one who shall not be named. I don't know. I didn't read the book, so whatever that guy's name is, the bad guy. Okay, that's falciparum. And then Vivax is like the understudy to Darth Vader, whoever that is, the understudy to the one who will not be named. Okay, the understudy to Satan. That is who Vivax is. Not as bad, but still bad. Okay, there are some specific diagnostic criteria that diagnose severe malaria. We'll go over some of them. Then the physical exam may be a little bit trickier. They do often have like petechia, which isn't seen at some of the others. You can get like really profound hepatomegaly, so enlarged liver. You can even get splenic rupture because the spleen gets so enlarged. You get a much higher percentage of like parasitemia in the blood than others. The thrombocytopenia can be worse. The anemia can be worse. The kidney, the liver injury can all be worse. Those are specific to severe malaria. Here's a chart straight from Up to Date. No free ads, but Up to Date always has a place in this video because we need them just so dearly because my brain is smooth and I can't store all the data. So this is definitions of severe malaria. And some of these are just like sick people get this stuff. So like poor GCS, like they're altered. Okay, like sick people get that. Um, Multiple seizures, if people get that, acidosis. Hypoglycemia is kind of unique to malaria, like a profound hypoglycemia. That's bad and particularly dangerous, and can be difficult to track, especially if you don't have reliable lab capability if you're in the middle of nowhere in Africa or whatever. Severe anemia, certainly you can get an anemia associated with severe illness, in American ICUs, but the severe anemia with malaria is particularly troublesome because the disease actually like ruptures the red blood cells, and so it's directly attacking them. AKI, jaundice, pulmonary edema, I'll talk about that one. I get significant bleeding, shock, and then elevated parasitemia. Okay, cerebral malaria. One of the hallmarks of severe malaria can be what's called cerebral malaria. So it is an encephalopathy that presents with like seizures, altered mental status, delirium, get focal neurologic deficits. Not often, but they can happen. Uh, and then weirdly, patients can have these retinal hemorrhages and cerebral edema that have long-lasting neurologic deficits. It would, dude, like you have to look for retinal hemorrhage. You're not just gonna like see it on a regular exam. You have to do a dilated eye exam and look in the back of the eye by an ophthalmologist. People who get these, so like in surviving children, 50% of them go on to develop long-lasting deficits. So that's pretty devastating. Whereas adults, only a very small percentage of adults go on to develop long-lasting neurologic deficits. So if you have cerebral edema, retinal hemorrhage, you're kind of in deep doo-doo for cerebral malaria. Sorry, I'm drinking. My throat's killing me. I can feel my voice going. Deficits are worsened by other poor prognostic factors, particularly like severe anemia, hypoglycemia, seizures, coma, and then a severe acidosis that is like unrelenting, cannot be improved. Those are all bad prognostic factors that worsen your cerebral malaria. Kind of like we had the TBI lecture where I just like raved about Harvey Cushing and what a freaking hero he was during the First World War. You have impact, you have primary neurologic injury and you're trying to prevent secondary injury. This is kind of like that. Like if you have a brain problem and you're hypoglycemic, that's freaking bad for you. If you have a brain problem, you start to have a seizure, like that's not good for you. If you have a brain problem and like your kidneys don't work good, that's also bad for you. So one of the mainstays of TBI treatment is to prevent second insults, and this is the same thing with cerebral malaria. It's all coming full circle. All right, non-cardiogenic pulmonary edema, meaning you have fluid in your lungs not caused from your heart. Okay, stuff in your lungs that isn't heart failure. Okay, that's what that fancy word means. This can progress to what's called ARDS, acute respiratory distress syndrome, which has some specific laboratory numbers. But pathology is like a little uncertain, but they think it's like related to sequestration, meaning sort of the drawing in of parasite red blood cells in the lungs and or cytokine leakage from pulmonary vasculature. So I sort of view this like trolley in the red blood cell talk that like was 49,000 minutes long. Like you have this immune thing that's happening, and like one of the places where the shit goes down in the immune thing that you have is just your lungs for whatever reason. And that sounds like a dumb way to explain it, but that's kind of how they're explaining it with trolley and with this. Some bad shit's happening to you. Its badness is manifesting in the lungs for a reason we don't understand, but we do see. And that's what non-cardiogenic pulmonary edema from malaria is like. That's kind of what trolley is like. And so there you go. Trolley's the lung thing you get from blood transfusions if you didn't watch that video or you don't remember. Super bad for you. This can develop despite anti-malarial therapy, by the way. Cool. Bacterial co-infection. We've made it to a longer portion than we did in the last video where it got cut off. So hopefully this goes all the way through. Bacterial co-infection. Not uncommon, which is a double negative. Follow closely. Common in severe malaria. That's what that probably should say. You should give broad spectrum antibiotics in severe malaria. You see somebody and you're in Africa and you go, this is malaria, give them the anti-malarial stuff. You should then, if they do have severe malaria, give them antibiotics. Which sounds dumb because antibiotics don't fix protozoa because they're not bacteria, but bacterial co-infection is common. Sub-Saharan Africa, they talked about salmonella infection, so cover for salmonella. Sure, whatever. Okay. These are all fancy words that all look the same to me. This is like that meme where it's like, this sign won't stop me because I can't read. All these words look the same to me, but they actually do mean different things. And so thank God I like wrote this whole thing out. And so I need this and I'm going to read straight from it to tell you what these words mean because these mean specific things when it comes to malaria. So recurrence and recrudescence, also in the stroke literature world, but recrudescence, relapse and reinfection are different things that require different treatment. So we're just going to go to the paper here. Recurrence and recrudescence can occur as a result of treatment failure. And then relapse and reinfection, these are difficult to all distinguish from each other. Recrudescence and relapsing infections manifest as a return of disease after its apparent cessation. So recurrence / recrudescence and relapse, you get better and then your shit comes back. There we go. Recrudescence often occurs within days to weeks, relapse with weeks to months. In recrudescence, parasites remain in the bloodstream undetected due to ineffective treatment or poor host immunologic response. So basically, you lower the parasite level so much that you don't appear sick anymore, and then the parasites say, yo, they forgot about us. We're like still around, and then they multiply back up and you get sick again. Okay, that's recurrence or recrudescence. In relapse, new blood stage parasites are released from dormant parasite stages, hypnozoites, in the liver cells, causing a repeat episode of peripheral parasitemia. So where's my thingy? Okay, so in relapse, you cured all the blood stage. You gave them doxycycline, you gave them methicillin, you gave them chloroquine, even though everybody's chloroquine resistant, but whatever. You cured the blood, okay? But you didn't give this stuff that cures the liver. And so months later, the liver one said, yeah, dog, we're out of here. And they bust out and they reinfect you. That's relapse, okay? Let's go back to where we were. Okay. And then reinfection is you just got sick again. That one's pretty easy, okay? Recurrence means the parasite level went low due to you didn't take your meds, poor immune response from you, then they got sick again. Relapse is you didn't fix the liver ones. They came back and they said, we're back. Reinfection is you just got sick again. Okay. All right. This meme doesn't mean anything. All right. Diagnostics and suspicion. Who has malaria? Dude, everybody got malaria. If you're in Africa, everybody has malaria. Malaria should be suspected in the setting of fever and relevant epidemiologic exposure. If you have been to Africa in the last forever, you could have malaria even if you live in Tennessee. Okay. Or if you are a place where malaria is endemic and you have fever, you should be suspected to have malaria. In people who are non-immune, most infections due to falciparum become apparent within 1 month after the exposure. And then endemic malarias in malaria endemic areas with stable transmission rates, seasonal transmission rates, malaria should be suspected in children with anemia hemoglobin below 8. So if somebody has like fever and unexplained anemia to you, they have malaria. There we go. You can get congenital malaria. You know, your mommy is sick with malaria, then gives birth to you, and you have malaria. That can happen. So febrile, ill-appearing neonate who's just recently born, they can have malaria. Not withhold malaria treatment pending diagnostics. Malaria is bad for you. I already told you, 40 flipping million people every day die of malaria. What did I say? 600,000 people a year die of malaria. Don't withhold the malaria treatment pending diagnostics. Okay, this is like, dude, like, you think they have meningitis or whatever. Like, you don't withhold meningitis treatment pending the LP. You just get the stuff going. Get the vancomycin, get the whatever you want. So the light microscopy and rapid diagnostic tests are most common. They both have their pros and cons. Here's light microscope. Thin and thick smears. It should be viewed as under the microscope as rapidly as possible after collection. I will just tell you, if you're in the military or you're in expeditionary medicine or you want to travel the world and save lives, you need to learn how to do thick and thin smears before you go or when you go to Africa, because you need to be able to do this if you have the technology available, like a microscope and whatever, because the ability to determine whether someone has malaria is very valuable. And there's lots of videos on this, there's lots of stuff on this. So that is one thing you should probably learn to do if you are going to have a microscope and you have the ability to do it. Requires some interpretation. Okay. These ones are more common, the rapid diagnostic tests, and then depending on the test, they detect different antigens. Some say what kind of species they have, some just say yes or no malaria. I don't think they tell you like how much malaria you have, like the level of parasitemia. Maybe there's some that do, but pros to this, and so like no electricity, you don't need a lab, you can just do it on the side of the road or whatever. You get the results pretty quickly. Limited training, all that's different than thin and thick smears. But like two is one and one is none, so you shouldn't just have one plan. So you should do the thin and thick smears if you have them. The cons is that it's qualitative data only, so no data on the parasite burden. So how much malaria you have, which is one of the criteria for severe malaria, is how much malaria you have. They don't have that. Like everybody, there's false positives and false negatives. So this one shows like on the bottom, it shows this is like you can't really see it here, but like bivalve, malaria, ovale, falciparum, and then falciparum or something else I can't remember. But Binax now is a really common one. Okay, treatment. So this was like a wildly long section of my notes, but the reality of it is we divide malaria treatment into falciparum and non-falciparum because falciparum is bad for you and it requires the most aggressive treatment options available. And then non-falciparum, generally less bad for you. And we also divide it into chloroquine sensitive and chloroquine resistant malaria. If you look at this map, it's like all chloroquine resistant. So only the green areas have chloroquine sensitive malaria. So it's like a very small part of the earth. Whereas like I said, like everyone who dies here. And there's essentially like no chloroquine sensitive malaria here in practical language. Okay. So I had like this whole thing on here about here's the drugs you should use if they're chloroquine sensitive, like here's the drug you should use if they're not. We're just really like not gonna do that. We're just gonna you're gonna go onto the CDC and talk about and just look up your malaria treatments. There's lots of different types. The main ones are these artemisinin combination therapy. Okay, that's the big one. Artemisinin combination therapy in combination with your liver hypnozoite stage treatment. So we'll kind of talk. And then treatment of severe malaria. Treatment of severe malaria requires parenteral, meaning IM or IV, tesonate, which is the ACT artemisinin combination therapy. It's called ACT. You'll see that a lot in malaria. ACT treatment, artemisinin combination therapy. So combo artesunate, so at least 24 hours, and then at least until the PO can be tolerated. Pregnant patients are more likely to develop severe malaria than other patients. If you want to go down, like, sorry, just go back to this. Like, if you want to go down this pathway of chloroquine resistant and chloroquine sensitive, there's a ton of literature on like, if you're chloroquine sensitive, non-falciparum, then you can get like these drugs. If you are chloroquine resistant, non-falciparum, then you can give these drugs. So like the equation would be if you are highly chloroquine resistant, non-falciparum malaria, the preferred treatment is ACT, so artemisinin combination therapy, plus a course of primaquine to prevent the liver stages. So like it just gets too complicated. It takes longer to say it than it would be for you to just like, I'm going to Africa. What should I have with me in my aid bag? Then just bring that. But you could do severe versus non-severe malaria, falciparum versus non-falciparum, chloroquine sensitive, non-falciparum, and then chloroquine resistant non-falciparum. So it's like it's too complicated. I had a bunch of charts on here before that I just took them all off and I said we're not going to do that anymore. There are some areas in the world where there is even like ACT like resistant malaria, but we're not going to get there. So pregnant patients more likely to develop severe malaria. They can also, their baby can get the congenital malaria. Hypoglycemia and pulmonary edema are more common in pregnant women. They don't really know why, but as in the blood lecture, the pulmonary edema, maybe it's an immune thing about having a baby inside you that causes some weird lung stuff. We don't actually know why. Fetal death, unfortunately, and premature labor are super common. These like high risk areas, like, I mean, dude, we're dealing with places like Chad and Mali and Niger, but these places that just like have limited infrastructure, the mortality can be just crazy high, like just so shockingly, devastatingly high. Relapse prevention. So for ovalian vivax species, so these two species leave stuff in your liver for later. They leave greeting cards of disease for later that we have to treat specifically, and the treatment of these is different than the treatment of acute malaria. Can like not hammer that enough. Like cannot hammer two things enough. One, falciparum, super bad for you. If you don't know what they have, treat them like they have falciparum. Two, ovalian vivax, leave greeting cards in your liver for later for you to 6 months later go, ooh, I get malaria again. You need to treat the liver stages as well as the acute stage of malaria. These are the main drugs, primaquine and tenefloquine. Primaquine is just better for a wide variety of reasons. Um, if you have G6PD, if you don't have G6PD, just keep moving, but it causes hemolysis. You can have hemolysis from both of these, so you do need G6PD screening before you do these. And so if you're in the military, they do screen you for this, I believe, when you like enter the military. I don't believe it's a disqualifying condition, but do screen you for these for certain meds, and you need to watch out for that. If you do have G6PD, that's not awesome for you, but you probably still can take primaquine. You just need to watch for signs of hemolysis. Hemolysis is like the destruction of red blood cells for a variety of reasons, but you're going to get jaundice, you're going to get pallor, you're going to get splenomegaly, kind of these kind of things. Tenefloquine has lower efficacy than primaquine does, and so that's like the main ones. And so, like, dude, tenefloquine sucks. Like, why are you telling me about it? Well, there are people who should get it. So it should only be used for patients who received chloroquine for anti-malarial regimen and not for those who received an artemisinin combination regimen. So if you were in a chloroquine sensitive area and you got chloroquine and you got better, those are the only people who really should get tenefloquine. Everybody else should not get it. Okay, recurrent caveats. If you said them, recurrent infection, you should treat with an alternative agent. Um, Options include ACT or atovaquone, proguanil, mefloquine, or quinine plus tetracycline like doxycycline. As with every antibiotic or antimalarial or whatever, choices should be made about local resistance patterns and where the infection was acquired. Like if you got malaria in Mexico, that's fulminantly different than getting malaria in Niger. Like you're not going to have falciparum. All right, prophylaxis. This is complicated. Lots of considerations here. Time and country, cost, comorbidities, like how long you want to take malaria before and after, uh, how good are you about taking meds, and then, the cost and availability to you. So like if you are an American going to Africa, like you'll just die of malaria. Like you need to take prophylaxis. But if you're going to be in a layover in, Johannesburg for a day, like that's different. So there are travel companies that do this. You can also go on the CDC website to look at your prophylaxis options, decide which is easiest for you. Some of them you need to start taking before you go, and most of them you need to start taking before you even go to the country. Then some you need to take for prolonged periods of time after leaving the country, like a month or two. And so that can be kind of annoying. But each individual person is just different. So I had like these like huge charts that initially were in this lecture about treatment of falciparum. Like this one is like so specific. Treatment of uncomplicated malaria caused by non-falciparum in non-pregnant individuals. Like the treatments just got too complicated, and then like here's the malaria treatments for uncomplicated non-falciparum malaria in non-pregnant adults and children. So like this one's huge, and so it's just easier for you to peruse these at your own leisure, and decide what's best for you between you and your doctor, other than me sort of giving these really niche topics of you need to take this amount of meds for this amount of time for this reason in this specific person. Prophylaxis is like that too. The most common ones are Malarone's pretty common, Doxy's pretty common. There you go. Control is massive. It's very disturbing. Somebody somewhere with a lot of money should do something about that. Under no illusions that this is not doing anything about it. Like maybe you can educate like 5 people on this, but So much do about it. I don't know. Bill Gates, he should take his money and use it to save malaria because to solve the malaria problem because it's just too many people in Africa are dying because nobody cares, frankly. If that was happening in Texas, then it'd be over in a day. Human toll is massive. If they went to Africa, they have malaria. Just assume that and start your treatment from there. Be aggressive with your treatment and broaden coverage early for other pathogens. So they have malaria, you think, don't wait till you diagnose them formally with malaria to start treatment. You should start treating them with antimalarials, and you should broaden if they have severe malaria to other bacterial etiologies. They recommend that you even do LP for people with severe or cerebral malaria. Okay. And then take a prophylaxis so you don't get malaria. Take it as prescribed. Lots of fun side effects in there, like nausea, vomiting, and weird vivid dreams and whatever. Okay, as always, we've come a long way since 4 subscribers. I think we have like 50 now. Stolen Valley Medicine, that's the channel. Subscribe, like, comment, whatever. I think that's what I'm supposed to say. The fun little thing that we do, but the thing here is always trust your gut. Do the absolute best you can for every single patient you ever see. Be a good teammate. Always stay in the fight. This will probably be my last video for a long time, but if I pick this up, it'll be a good time. I've really enjoyed doing this. I think we have a really good baseline here. Share these far and wide with whoever you want. If they're interested in military medicine, if they're interested in malaria, if they're interested in anything, share them as wide as you possibly can. The goal is just to help people. Nothing I get out of it other than helping people. So thanks for sticking around, guys. I think I might have a source thing on here. Or it might just be done. But thanks. There you go. There's all your sources. Cool.